So hello and welcome to My Macular and Me, our monthly webinar bringing you all the very latest news about age-related macular degeneration. I'm Kathy Elf and I'm the Chief Executive of the Macular Society, and it's lovely to have so many of you with us this evening. So thanks very much indeed for joining us. Now, if you have wet AMD, and I'm imagining that quite a few people in the room may well be in that position, then you have probably been a regular visitor to your eye clinic, hospital eye clinic, to have injections of a drug that is, of course, designed to slow down the progression of wet age-related macular degeneration. Now, we know from our helpline and from all kinds of sources that there is a great deal of variation around the country as to people's experiences of eye clinics and of the treatment and how well they are, their pastoral care is looked after, how well they're signposted to other support and so on. There's a lot of variation around the country. So how do you know how well your hospital eye clinic is doing? And how does the NHS know how well hospital eye clinics are doing in treating their patients? And how do they compare the results that hospital A gets versus hospital B? Well, the answer, of course, is audit. Auditing those hospital results, gathering data from the hospitals, analysing it, and gaining some insight from that exercise. This collection of information shows us how hospitals do compared with one another, and that's quite an important thing for both patients in the NHS and the doctors to understand. So my guest this evening is Martin McKibbin, and if you've been a regular at these webinars, you may have met Martin in the past. He's been a consultant ophthalmologist in Leeds for more than 20 years. His clinical and research interests are in vascular and inherited eye diseases of the retina, and also in giving injections for AMD, and he's been giving injections for AMD for 15 years, so he's got pretty good at it by now, I think, Martin, that's probably true to say. Now, he was appointed the clinical lead for the UK AMD Audit in 2020, and now in 2024, this audit is up and running now fairly smoothly, and Martin has just produced his second report on the AMD audit results. So straight over to you, Martin, if that's all right. And please do tell us what your latest report is showing about AMD around the country. Martin McKibbin, ladies and gentlemen.
Thank you, Kathy, for your kind introduction. Can I just check you can see my first slide?
Can? Yep, perfect.
Great. So I was slightly worried when you said when you were going to tell me how long I've been a consultant for, because it's quite a long time. I did have a flashback though to the time I gave my first intravitreal injection, and I think that was in 2006 or 2007. And I never, in my wildest dreams, thought I'd still be doing it now. I think I assumed there'd be something much would have come along. But anyway, at the time, it was a game changer in terms of treatment, and I think it's still a fantastic treatment. The problem is it just needs to be given on a regular basis. So I had also temporarily forgotten that I've done a Macular and Me webinar before. So hopefully that means I wasn't awful the first time round, and I won't be awful the second time round.
On the contrary.
Okay, so I'm just going to get my slides to advance. Okay, so there have actually been two. For the second annual report, there were two reports that were published in March of this year. There was the full report, which is 86 pages long. So if you were struggling to get to sleep, or if you woke up and couldn't get back to sleep, that might be something to start off reading. But there was also a patient summary report, which tried to give a snapshot of how the UK is doing in terms of treatment for the wet or neovascular form of AMD. And so my plan for tonight is to have a few introductions just to set the scene and to expand on what Kathy said about audit and the standard measure of vision. And then I was going to give you some key results for all the participating sites, highlight the variation that we found, and then the recommendations that we've had. And then towards the end, I sort of need to ask for your help as well as to answer some of your questions. So Lord Darcy several years ago produced a long report about healthcare and the quality of healthcare. And he said there were three key elements or dimensions of quality healthcare. One of them was monitoring clinical effectiveness. So that was how well do patients respond to treatment. One of them was patient safety, and the other one was patient experience. And clinical audit is a quality improvement tool that allows organisations to monitor two of those, namely how effective is treatment and also how safe is it. And it's often referred to as a cycle. So you choose a topic, you identify the standards that you'd like to be reaching, you measure your local performance, or it could be national performance, you compare how you're doing versus how you'd like to be doing, and then you look to see if there are any changes that need to be made. If there are, you implement a change, and then you repeat the audit, and essentially you keep going, and that's why it's referred to as an audit cycle. And there's a difference between audit and research. So research is often said to be finding out what is the best thing to do, whereas audit would be trying to see, are you doing the right thing? So research is finding out what it is that you should be doing, and audit is really checking that you are doing that particular thing. So the NHS uses clinical audit just really to make sure that care has been given well. And as I said, it allows organisations to compare how they're doing with their peers or to national averages. So I'm sure none of you are old enough to fall and break your hip, but imagine an elderly relative did, and he or she was rushed to hospital. So their care would be picked up as part of the National Hip Fracture Database, and that's a form of clinical audit. And as part of that, it would be recorded as to whether they were admitted to the correct ward, how quickly did they have surgery, and then were steps taken to try to reduce the risk of another fall and another fracture in due course. So it uses routinely collected clinical data to see how organisations are doing, and then to enable monitoring of that care. And then if somebody also then went on to have a hip replacement, I suppose as part of their fracture, then data about that hip would be collected as part of the National Joint Registry. That would enable the NHS to track if particular artificial hips were doing better or worse than some. And then if there was a problem with a particular type of hip joint, it would allow all the patients who've had that hip joint to be contacted. So the data for clinical audit is usually collected as part of routine clinical care. There's no extra input to try to collect special data that's not normally recorded. And a key thing is that when it's analysed, it's done so anonymously. So data for the audit from Leeds, for example, goes out to the hospital, and as soon as it goes out to the hospital, all of the patient's data is removed. So there's no names, there's no addresses, there's no telephone numbers, and the NHS number and date of birth, they're all gone. So it's anonymised data that's looked at, and there's no method of identifying people. And because of that, it's really your data, and this audit is really your audit. So it's an audit of how your care is being given. So by way of introduction, I will be referring to letters, and although black letters on a white background is not a very good way of assessing your vision, and a lot of patients tell me that, so and it also doesn't reflect near vision, it's the standard method that we have. So when I talk about letters, I mean how many letters on this standard eye chart did you read, and if there's a deterioration, it means if the number of letters goes down, it means your sight's getting worse, and if the number of letters goes up, it means your sight's getting better. And there are a couple of key things as well. So there's a standard definition about a significant change. So a significant change would be 3 lines of letters, 3 lines or 15 letters on this eye chart. And that's meant to be the type of change that everybody would notice. So you don't have to be a very good witness, you would definitely notice this sort of difference. So that's a significant change. And then also when I talk about good vision, I mean this line that some of you might be able to see fairly low down to the bottom of the chart. So to have good vision, you've got to be able to read more letters than that at the distance of 2 or 4 meters, however you do the chart. Whereas poor vision means you can't see any letters on the chart at all. So just try to bear those in mind. Okay, so for the second report, which was published in March of this year, we invited as many organisations who we thought were providing NHS-funded treatment for wet macular degeneration. So that includes both NHS trusts and independent sector providers. And so we got 80 organisations signed up to participate. And so we had representation from all 4 home nations and from the Channel Islands. But some of the 80 either didn't have data for the correct year. So we were looking at eyes that started treatment in the year 2021/22. So that's an NHS year or a tax year rather than a calendar year. Or they had very few eyes and they were excluded. because we want to make sure we're collecting data from centres that are treating a reasonable number of eyes or patients. And then 4 organisations felt that their data quality was so poor, and I'll come to that in a minute, that they asked for their data to be taken out while they mulled over how to improve data quality. So in the end, we had some data about 23,400 people and more than 26,000 eyes. So that means a lot of them, there was only one eye that started treatment in this 12-month period, but some people had both eyes that were treated. Either both eyes started treatment at the same time, or one eye was treated first, and before the year was out, they were having treatment for their second eye. And from now on, I'm very much aware that it's people that have eyes, not the other way around. So I'm going to talk about eyes, just because there are bigger numbers of eyes rather than people. And so there are some key things that we try to do within the audit. One is to look at outcomes for all of these 28,000 eyes. And we're particularly interested in the quality of the data, because if the data is not collected very well, then you can't really draw any meaningful conclusions. And for somebody who works in Leeds, that's very, very relevant. You might remember some years ago that children's heart surgery was stopped in Leeds because of concerns about safety. And the parents of the children who had been operated on were up in arms, and they said that care was very good and they couldn't see why treatment had to be stopped. But it was definitely stopped for quite some time. And then when the data was resubmitted and reanalyzed, it turned out that actually the performance in Leeds wasn't as bad as it was first thought. And the problem was all down to the data quality. So the initial data that had been submitted to the audit was poor. Therefore, the conclusions were valid for the data that was submitted, but they weren't correct. And it was only when the data was resubmitted and the data quality improved that heart surgery started again. So we're interested to know, is the data quality high, and therefore can our conclusions, can we be confident in our conclusions? We want to know about vision, so vision at the start of treatment and vision typically a year after treatment, but also 2 years and perhaps longer intervals. We want to know how treatment is being provided, so how quickly does it start? Ideally, are there any delays? And what's the average number of injections that an eye might have over 12 and 24 months? And then we're interested in safety. So we try to capture that data for everybody, but then for organisations, we're interested in looking at variation to see how the outcomes of treatment differ from one centre to another, and also to enable those centres to compare how they're performing with their peers, which might be in the area or in the country, or it might be organisations similar size, and then to hopefully give them some information which will allow them to implement any changes if change is necessary, or to be confident that they're actually providing very good quality treatment. So in terms of data quality, I think it was okay. So this is 21-22, so that was pretty much peak COVID time. And certainly in Leeds, we were moving from paper records to electronic records. And although the vision was collected every single time that a patient attended, it perhaps didn't get into the computer very often. And I'm sure that was fairly representative of what was happening throughout the NHS. So if you looked at the proportion of eyes that had a vision measured and recorded on the computer records, both at the start of treatment and after 24 months, then it was 90%. So that's good, but I think it could be a lot better. I'd love to be up to 95% or even higher, but it's reasonably good. One problem we had was that about a quarter of patients didn't have a follow-up at month 12. So that doesn't mean they didn't come back on that specific day 365 after they started, but they didn't come back on that day plus or minus 2 months. And I'm not sure what's going on there. I think some of the organisations felt they were moving from one electronic medical record to the other, and they'd lost some patients that way, but I'm not really sure what was going on. And then other areas in which the data quality was poor were mainly around referral from primary care. So most patients that I see would go to see an optician first because they've got a problem with their vision and they want to know if it's glasses that will help, or the optician might pick something up before they're aware of it. And then they get referred into hospital or an independent sector provider, they get assessed and diagnosed, and then treatment started. And one of the key targets we want to show is how well centres are doing in terms of getting that treatment started within 2 weeks of receiving a referral from an optometrist. So for all 28,000 eyes, we only knew about a referral for about a third of them for almost 8,000. And even then, we weren't really sure if the referral was for cataract or glaucoma or something else. So we couldn't really work out if it was for macular degeneration. But anyway, for those 8,000 eyes, we found that just over 20% was getting treatment started within 14 days of referral. And that's something we'd like to see increase. But I think because of the concerns about the data quality, we're not really very confident in that measure. And hopefully that's something that's going to improve as time goes by. So the areas we've really struggled for data quality are in terms of capturing the date at which somebody was referred from an optometrist, and also the follow-up. So I know from a webinar that I did with the Society several years ago that a key thing for patients is about hospital cancellations and delays. So if you get told to come back in 8 weeks, what I know most patients really hate is when 8 weeks comes and they still haven't heard anything and it goes on and on. So what we'd like to capture is how often are appointments delayed compared to what was planned, and we don't have good data about that yet either. So in terms of the 23,400 patients, most of them were female, and for people having their first eye treated, the average age was 81 years, and for people having their second eye treated, it was 83 years. And that's very similar to the first annual report. And then if you recorded the number of letters that all those eyes read, and you look for the value in the middle, so it's not quite the average, but it's often close to the average, then the baseline vision was 60 letters. So that's not good enough to drive, but it's probably good enough to do quite a lot of things, particularly with stronger reading glasses and a good light. And that hasn't changed from the first report. So both of the first reports were captured eyes that were treated during COVID years. So I'm hoping that's going to improve. And I've left a flag of Sweden down at the bottom because Sweden also has a macular registry. And my Swedish isn't very good, and I can't face putting the entire document to Google Translate. But in Sweden, the starting level of vision is 5 letters better, is 65 letters. So there must be something that is happening in Sweden that means that patients are getting through the system and into having treatment earlier than they are in the UK. So perhaps that's something I could learn from in the future. And then in terms of the care pathway, so I said that starting treatment within 14 days wasn't great, but I think there's more concerns about the data quality than that. And one of the things we wanted to look at was getting your initial monthly treatment done quickly. So typically people have 3 or 4 injections at monthly intervals at the start of their treatment now. And the audit was quite keen to show how often was that treatment completed within 10 weeks. So that allowed a little bit of delay. But we thought 10 weeks is a reasonable target. And about 2/3 of eyes had that treatment given within 10 weeks. And I'll come back later as to why that's important. And then the most common number of injections in the first year of treatment was 6. That's slightly down from the year before when the figure was 7, but it's still a reasonable amount of treatment for the first year. And then it gets a little bit less into the second year. And then many of you will be aware that injections are now not so much done by medical staff, but by other trained non-medical staff. And that's certainly the case in Leeds. So across the board, almost 70% of injections were done by trained non-medical staff. And that's really been a necessity. There aren't enough doctors to go around. Doctors are very expensive. So using trained non-medical staff is a way to make sure we have enough capacity to try to provide timely treatment. So at the end of the first year, and that was our key outcome, the vision had improved from 60 to 65 letters. So for a lot of people, the improvement was small. About 90% of people had kept stable vision and avoided a significant loss of vision. And I said before, significant means their vision had deteriorated by less than 3 lines on that chart. So 90% is pretty good. So we're fairly confident that treatment will stabilize vision in the majority of patients. And that's almost double what it is in terms of if you'd done nothing for a year, probably about 50% of people would have avoided that moderate, significant visual loss. So we raised that figure to 90%. And on the flip side, about 20% of people had a big improvement in vision. So they had a gain of at least 3 lines of letters on the chart. And if we'd done nothing, that would probably happen in about 5% or so. And that data comes from some of the clinical trials which were done many years ago before these treatments were licensed, whereby some of the eyes were randomly allocated treatment and some of them were given a sham treatment. And I think we worked out from the eyes that were given a sham or a dummy treatment that only a small proportion had an improvement in vision. And then the other outcome we looked at was how common was it that I would have a good level of vision? So I said that was, I had that low-lying red line on the chart. So that's 70 letters, which is pretty close to driving vision, actually. And the proportion of eyes that had good vision went from just under 30% to just over 40% after 1 year of treatment. And then in terms of safety, I think on the whole, we thought treatment was safe. We didn't capture information about what might be regarded as more minor problems. So that could be bruising around the eye, how painful it feels during and after the injection, and often seeing bubbles or black dots in the eye, because that's just not very well recorded in any of the electronic records. So we looked for inflammation, which is a reaction to the treatment or to the drug. And we looked for a suspected infection inside the eye, which is probably the most serious complication of all. That's something called endophthalmitis. And we thought that the number of times the number of injections you would need to get one case of that was about 6,500. So the risk of getting a suspected case of infection in the eye after treatment was very low. But I suppose if each patient is having an average of 6 injections in the year, then it means per year of treatment, the risk of getting at least one episode of this is about 1 in 1,000. But it seemed to be safe. And importantly, there was no difference in the frequency of any of these complications, whether it was a doctor who gave the injection or a trained non-medical practitioner. And if anything, the frequency was slightly less with trained non-medical practitioners than with doctors. And then because we've got such a big data set, and it's not the biggest data set in the world, but it's one of the biggest ones, we can start to do some additional analyses. So we were trying to work out which eyes or who is it who gets the best outcomes. So going back to this idea of good vision, which is that lower red line on the chart, or 70 letters, so close to driving vision. So if you've got that level of vision at the start, you've got almost an 80% chance of keeping that level of vision with treatment. So treatment is very good at stabilizing things, but it's not so good at improving the vision. So if your vision was poor and you couldn't read any letters on that eye chart I showed you before, then you've only got about a 5% chance of getting a good vision outcome, despite having attended and complied with all of your treatment over the course of the first year. So definitely we know that a key thing is to get treatment started quickly while the vision's still quite good. And if that doesn't happen and your vision's quite poor, then it's unlikely you'll ever end up with a very good outcome. But I guess treatment might stop it getting even worse. And then we also learned that there's an age-related factor in this. So if you took all the people under 70 compared to the people over 85 when they started treatment, about 50% of the younger group would end up with good vision compared to just over 30% of the older group. So not only does your baseline vision influence your outcome, but so too does your age. And then we were also able to do something called statistical modeling. And that was something that I first came across during COVID, when there were various plans done to say, if we did this, what would be the effect? So we could do statistical modeling on our database to try to work out what were the key bits of the care pathway, or what were the key characteristics of eyes that meant they were more or less likely to get a good outcome. So in terms of getting a good outcome, one thing we found was that it was quite important to get these initial 3 monthly injections done quickly. So if you looked at the eyes that did get these injections done within 10 weeks compared to the eyes that didn't, then the eyes that did get the injections done quickly were about 40% more likely to get a good outcome than the eyes that weren't. So not only do we know it's important to get treatment started quickly, but we also now know that it's very important to get those initial monthly injections done quickly without any delays. And that's something that we've started to prioritize in Leeds. And then perhaps not surprisingly, if you looked at people with diabetes mellitus or eyes with glaucoma, they're less likely to get a good vision outcome. And that probably means that part of the reason for their sight being poor is age-related macular degeneration, and then there are other things, and we're only treating one, so then they're less likely to get an improvement. So that was a bit of a snapshot as to how the outcomes for all the eyes that were treated. And then one thing we were keen to look at, and this is relevant to clinical audit. So we've worked out what happens on average, but we also want to know what happens in the individual centres. And some variation between providers of any treatment is to be expected. It might relate to the age of the population, or to the size of the population in that area, or it might relate to how the service is provided. So it could be a difference between a city centre location or a community centre, or it might be a very small centre that's just started compared to a very big centre that's been going for a number of years. But when the variation is said to be excessive, then it's often an indication of waste and inefficiency. And excessive variation often leads to poor outcomes. And I suspect that the data I'm going to show you fits into the category of being excessive variation. So if you looked at the baseline vision, the most common level of vision was 60 letters on the chart. But between centres, between the 60 centres that were participating, it ranged from 27 to 70 letters. So there's definitely something that the centre with a 70-letter median vision is doing that the other centres are not. And that's something we need to learn from. Similarly, if you looked at the proportion of eyes in each centre that got their initial 3 injections within 10 weeks, it was about 67% overall. But there was a huge variation from almost nothing, 1% up to more than 90%. So again, a big variation between one centre and another. And then if you looked at the vision outcomes, that's what we're after. We're trying to get vision as good as possible. The proportion of eyes in each centre, the proportion of eyes overall that got a good vision state was about 42%. But if you looked at this by centre, it varied from 6 to 65%. So I don't know what's considered normal variation, excessive variation, but I do think this is evidence of an excessive variation. And with the modelling, we can create this thing called a funnel plot. And I'm sure there are some mathematicians, statisticians amongst you who understand this fully, but I definitely don't. However, what you really want, all the dots on here are centres. And what you really want is to be a centre above the green line. So green is good, and green means you're doing much better than average. A lot of them are in grey in the middle, and they're doing okay. And the concern here would be the centres that have got a red circle. So they're ones that are doing less well than expected. And a couple of them are doing just a little bit less well than expected. But 1 or 2 of them are doing quite a lot less well than expected. So what we can do then is we can identify the centres that are doing less well than expected with our modelling. And I had the pleasant job of contacting the centres doing well than expected by email, but I had the very unpleasant job of contacting the centres who were not doing quite so well. Just to notify them that we thought they were probably an outlier. There was something that they were doing that meant that eyes treated in their centre were not doing as well as expected. And that's mainly the idea of clinical audit. And hopefully the report and the findings will have given those the doctors and other staff in those centres the ammunition they needed to try to address whatever problems were going on locally. So in the report, we made recommendations for anybody who would listen. In terms of providers, so that's either your local hospital where they're providing you with treatment or an independent sector provider. We suggested that centres move towards electronic records where they're not doing that already. And I'm amazed that some hospitals still have paper records. That centres make an effort to review the data quality, so particularly around recording vision, both at the start of treatment and at the end of each year. And then I mentioned about capturing data of referral from primary care and also about the planned follow-up. And that we encourage centres that are participating to benchmark their performance and to take any necessary actions. So the necessary action might be to praise everybody if you're doing fantastically well, but quite often nobody's doing well across all the measures. There's one or two that they might not be doing so well on. So that might be something that they could choose to address, and there would encourage people to nominate somebody who's going to lead on that, and then to agree a timescale in which it's going to be done, and to feed back to the department any action that's been taken. And then the key things that we think would give best outcomes would be to prioritise referrals from primary care, so these are for optometrists, and to get these patients seen quickly so that you can start treatment when it's appropriate to do so as quickly as possible and when the vision's still good. And we know that's a key thing to try to get good outcomes. And also we know that you've got to get that initial phase of monthly treatment done as quickly as possible, and that's another way of choosing the outcomes. And then I talked about the fact that we know that about 20% of patients are not around a year after treatment. And we can capture how many of them have died, and it's nothing like 20% have died. It's a very small percentage. So some of them might have been away on holiday. Some of them might have been ill for other reasons, but I suspect quite a lot of patients have started treatment thinking they're going to get a fantastic improvement, but they haven't got that. So one thing I think that we can do is to start to use the data from this AMD audit to give patients a clear indication about where they're likely to end up based on the 26,000 patients, 24,000 patients treated in the year that we've just reported. So they'll have a good idea where they're likely to be, and that will help them to make an informed decision about treatment. And I think that way will hopefully stop the number of patients who start treatment and then realise it's not really giving them what they want, and then who vote with their feet and decide not to continue with treatment. So in terms of benchmarking, there is a National Ophthalmology Database, and doctors and non-medical staff working in those centres can look at their data. So I hope some of you can see this. It's a series of lines, and each line is a centre that's providing treatment. So there are probably 60 there. Some of them are in green, and those are centres in England, and some of them are in grey, and those are centres outside of England. And Leeds is sitting smack bang in the middle. So although I'd like to be at the left-hand end, which is very, very good, we're pretty much in the middle, and we're definitely not right at the bottom, which is where I think nobody wants to be. So this is a way that I can monitor how we're doing, and I can track over a period of time whether we're doing better or worse. And then the idea of benchmarking is really to compare how we're doing, for example, in Leeds with the national figures. And then also in this report, we've got some quality markers. So these were levels of performance that we thought most places should get to, and then which the very top centres should get to. And the hope is that more and more centres will get into this acceptable measure of performance and then desirable measure. So here you might be able to see that on the top row, I've got recording vision. So in the most recent audit, Leeds had that recorded for 95%. The year before was 91%. So we seem to be going in the right direction. And that compares to an average nationally of about 90%. So we seem to be doing okay for that. However, if you move down a bit, there's one there about completing these initial 3 injections within 10 weeks. So in this year of the audit, we only did that in about 64%. The year before we were doing better, it was 72%. So we're getting worse. And if you look at the average figure, it's about 67%. And the acceptable standard is 75%. So on every measure, Leeds was failing. And so we chose this as our just one thing to do. So we've prioritized that. And I think we've turned it around now. So the last time we looked at eyes that were treated in 2023, that figure had gone up to 85%. So that illustrates how we've used the results of the national audit to choose just one particular area where we think we're not doing as well as everybody else is, and where we think we should be. And we've used that to change how care is provided locally. And then we also made some recommendations for patients in the report. So I guess you've got to have macular degeneration probably to know the report exists. But anyway, you might come across it beforehand. So I think it's probably important to ask for information about what is likely to happen or what has happened to eyes with that particular level of vision, so that you can make an informed decision about starting treatment. Historically, we've always used information from clinical trials to guide patients to what they're likely to be, but it's commonly accepted that the results you get in clinical trials are not the same ones you get in real-world practice. So now we've got information from real-world practice which can guide patients as to whether it's appropriate to start treatment, or whether they might decide that actually it's probably not going to be worthwhile. I think we're very keen that if you're having treatment for your first eye, that you have regular checkups on your second eye to try to pick up signs of wet macular degeneration developing in that eye. And certainly in Leeds, every time you come out to the clinic, you would have a scan on your treated eye, and you'd also have a scan on your other eye. And that way we can often pick up signs of wet macular degeneration starting in the second eye, even before people are aware that it's starting. And I think if treatment is ever paused, so sometimes you have regular treatment in one eye, and then the decision taken to hold off with treatment for now, or it may be that the interval has been extended longer and longer and longer, or it could be it stopped perhaps because it's not working. And I think in that situation, you need to be confident that you know who to contact and how to do it quickly in the event of any new symptoms. So just as it's important to start treatment quickly when the problem first happens, I think if your macular degeneration becomes active and your vision is affected again, that's also important to restart treatment quickly. So you need to know about that. And then I think the other thing is that if your centre's not participating, then perhaps you could encourage clinical staff to sign up, and you could ask them why they're not doing it. So it may be that that they don't have an electronic record, in which case you can't take part. You've got to get electronic records first. We don't want anybody to be going through paper notes and extracting the data and adding that in. That's not appropriate. Or it could be that your centre was one of the 80 that signed up initially but didn't have enough eyes, or didn't have eyes treated in the particular year. So probably what you want to do is ask one of the consultants or ask one of the other non-medical practitioners, why are they not taking part? And there may be a very good reason. Maybe they are taking part already, but they didn't have any eyes or they didn't have any records. So I think start off asking them. And if somebody says, oh, there's no enthusiasm, we can't get around to it, then I think you can express some surprise about that. You could also consider contacting the patient advocacy and liaison team. And you could just say that without data from the audit, how do you know that you're getting good quality care in your centre? Or you could write to the medical director of the organisation. So the medical director is often interested about how care is given and the outcomes. Or you could write to the chief executive. And you might find that actually the clinical staff have campaigned to try to take part for a number of years, and it just needs a bit of extra help to get the organisation to sign up. And then in preparation of the meeting, Kathy asked me, so what's the relevance of the audit for patients? You know, why is it important? Well, I think whether your centre is participating in the audit or not, I think this gives you an idea about how care is currently being provided across the UK and of the sort of about the sort of service you should expect to be receiving. And I think if your centre is providing, it enables you to see how your centre is doing compared to others. And that's the idea of benchmarking. And it may be your centre doing absolutely fantastically, in which case, hopefully that'd be very reassuring. But actually, it could be that your centre's not doing quite as well as it should be, in which case you might have the option of switching to another centre that's doing better. But quite often you could help to complain along the lines I suggested before, just to try to help to get some more attention to improve the service delivery. And as I said, I think it gives you some information to drive some changes in how care is delivered if they're needed. So going forward, we're extracting the data, the anonymous data from participating sites now, and our plan is to get the next report done before the end of this year. So we'd like to get it done within 6 months of the data being extracted. And we're continuing to work with the companies that make electronic records for use in eye clinics to improve the data quality, especially around capturing the referral from the start of treatment and follow-up. But I must say that's quite slow, and I think this is probably not a priority for some of the companies. And I'm aware that we need to try to reduce the variation between centres, particularly in starting vision, because that's a key thing, and getting the initial phase of monthly treatment done quickly, because we know both those are key to getting good outcomes. And over time, I'd like to show that we're reducing the variation, so we're making the gap between the best and the worst smaller. And actually, we're also making sure that more centres are exceeding what we think are the thresholds for acceptable and desirable quality. So that's what we'd like to do going forward. And then I mentioned that for clinicians like me, we can look at data for our unit on the National Ophthalmology Database website. And you can do that now as a patient having cataract surgery. So here I've got a screenshot from the National Ophthalmology Database for cataract surgery in Leeds up to the end of 2023. So it's looking at a particular complication that you hopefully would never have, but some places, some patients do have this complication. So it says for Leeds during that period, there were just under 2,000 operations. The expected rate would be about 99% of eyes would avoid this complication. In Leeds, it was 99.2%. And then there's a tick to say it was within expected limits. So that would be reassuring. I think if you're a patient expecting to have cataract surgery done within the Leeds hospital, it would be reassuring to show that care provided in Leeds is on a par. I couldn't say it's better, but it's certainly no worse than what you would expect. So that would be reassuring. And I think going forward, what we want to try and do is get some of the age-related macular degeneration data onto the website. So the first time I did one of these webinars, I asked the attendees what was important for them. And I know that car parking is important, getting your appointment letters on time, reducing the number of delays, and having time to discuss care with a clinician rather than, so it's being treated as a person, not as something on a conveyor belt. But we don't capture all that data within the audit at the moment, although that's something we might do in the future. So the things we can look at are about starting treatment quickly, getting this initial phase of monthly treatment done on time, about complications, about delays, and about vision outcomes. But there's quite a lot there, and I don't know which one of those would be most important to you. But what we really want, so what we'd really like to do is to find out what are the key things that you feel would be important. And that would then enable you to see how your centre is comparing to all the other centres or just those in your area. And then I also want to know whether you want us to use color coded, so do we highlight areas where practice is very good? Do we name and shame areas where performance is bad? So it's that sort of information which I'd be keen to get out from you. And perhaps you could either tell me that in when we go over to questions, or I might be able to persuade Kathy to do a member survey in due course. So I just need to thank everybody. Apologies for the fact that I was told I've got a Macular Society logo, which is so old it hasn't been around for 6 years, but it was just one I found. So inevitably, behind me there's a big team. So I need to thank Glyn and Beth at the Royal College of Ophthalmologists who helped to run the audit. Paul, Martin, and Charlotte, who are statisticians in the National Ophthalmology Database in Gloucester. And then the audit has an advisory group. So Geraldine from the Macular Society is part of that. And I've got some other clinical colleagues. And then I need to thank the members of the Macular Society, both staff and members. Not only have they helped to provide funding to get this audit up and going, but essentially the members it's your data and essentially it's your audit. So thank you very much. So I'm going to hand over to Kathy. And you might need to give me a minute because I've just knocked a glass of water across the table. So I'm going to go and quickly mop up the glass of water and then I'll come back to any questions.
That's fine. Okay, we don't want you to explode your laptop while you're doing that. So in the meantime, please put any questions that you have in the chat, but also please put into the chat what you think it's important for this audit to collect, the information that you would like to see about your centre on the audit in future, so that Martin can start to build it into the plans for the future iterations of this audit. So put it into your put it into the chat if you would, and it may well be that we will do a member survey actually to find out what are the important things that people need to know about their clinic. So somebody's saying thank you for the good clear slides in large print, Martin. Yes, they were extremely easy to see. So thank you very much indeed for doing that. So put your questions into.
That's no problem. I've been well coached by Kathy. You see, big slides,
big slides.
black on white, by and large. That's what I tried to do.
So what can people see about their own clinic at the moment then on the website? Is it patients don't really have access to this, but they can ask their clinician, how did you do in the National Ophthalmology Database AMD audit?
Yes. So at the moment, you can definitely see information about cataract. So the cataract audit's been going for possibly nearly 10 years. So that's much more mature. And for cataract surgery, you can look up this particular complication, which happens during an operation. And you can also pick up eyes that have had a big drop in vision after treatment. So that's not something we would, after cataract surgery, that's not something we would expect. So you can see that not only for the hospital or centre that you're going to, but you can also see it for your individual surgeon. So you might, for example, look at leads and say, I definitely don't want Martin McKibbin to do it. But that's mainly because I haven't done any cataract surgery for probably 5 or 6 years now. So I'm the last person you want to do it. But anyway, you might find that one of my colleagues is absolutely fantastic and one isn't so good. And you could request that you wanted it done by somebody else. So for cataract surgery, there's quite good data. For macular degeneration, as far as I know, there isn't anything at the moment, but that's what we want to know. So we're collecting a lot of data. And what we'd really like to know is what would be the most important bits of the data for patients, and also to get some idea about how to present that. That's something I'd quite like to get a bit of a steer on. And then hopefully before we get the next report, perhaps in 6 months, we will have some data on the National Ophthalmology Database website, which would allow patients to look at their centre and to see is the one that's doing better nearby, or to be reassured that actually their centre is doing absolutely fine and probably better than other places locally. Sorry, Kathy, you're still on mute.
Sorry, myself. Somebody's asked, can we rate the centres ourselves? And I guess there could be a way of rating the centres, you know, sort of TripAdvisor kind of rating. But the point about the audit, I guess, is it's the comparison, isn't it? Because if you've only ever been to one centre, it might look really good. You might have had a really great experience, but actually you then compare it to the one down the road. You think, well, maybe it wasn't that good after all. Or maybe you go, hey, I was right. It's really brilliant. It's the comparison that's important, isn't it? I guess.
Yeah. Yeah, and I suppose that we do have a few patients who move from Leeds to other places, often to go and live with family, or the reverse. So I guess they would have experience of treatment in Centre A and Centre B, and they might be able to tell me that actually Leeds is awful. It was so much better when I was in York or Scarborough, and that's fine. I'd quite like to get that feedback, or they might say the opposite. But there are not, that's a minority. So I think, as you quite rightly point out, for most patients, they have treatment in one place and they don't know if that place is fantastic or not. And certainly my colleagues and I spend quite a lot of time trying to make sure we have enough appointments and getting the clinic running smoothly. And it's often a battle, particularly in summer holidays. So we think we're doing fantastically well. But so does everybody else. And it's probably only when you have data from an audit that you can actually compare how your centre is doing relative to others. And that you realise, and that then gives you the opportunity to work out that you're not doing well on one level. What we'd quite like to do as a long-term goal is to collect some patient experience measures. So that's not so much about how your treatment was given, it's more about your experience of having that treatment in the first place. And that's something I've talked about for a couple of years, and to my shame, I haven't quite got around to doing it. But it's something that's on the back burner and something that we would like to do. So I guess if that was around, then yes, you could rate your clinic and you could say the car parking was awful, or there were lots of delays to follow up, or the staff were rude and I felt as if I was on a conveyor belt. But until then, I guess the way you could do it would be to contact your patient advocacy and liaison service. Or there's also the family and friends test, which the hospital is quite keen to promote when the feedback is good. But if the feedback's poor, I think it's a measure that the hospital uses to collect some data.
What difference do you think COVID, because as you pointed out, a lot of the data collection was during the COVID pandemic. So the first year of the data, people were kind of getting used to it. Second year, you're in COVID. Do you think we might see something quite different next year? Or do you think actually COVID, it depressed the amount of activity, but not necessarily anything else in the data necessarily?
So yes, I think the amount of activity is probably true. So comparing this recent report with the previous one, we only had 4 more centres, but we had 30% more eyes. So there's no way 4 centres accounted for a 30% increase. So I think what we found was that every centre was doing more treatment in the most recent 12-month period we looked at compared to the year 2020, so just after COVID started for the first 12 months. So I think there were a lot of patients who who ignored their treatment or ignored their eyesight problem or didn't want to seek further attention during that first year. And then we will have picked up some of them in the second year. So my hope is that we might show that there's a smaller increase in future years, but we'd also see that the level of vision at the start of treatment is a bit better. So I suspect it's hopefully, well, one of the reasons why it might appear to be worse than Sweden is because either patients didn't seek attention as quickly as they might have done, or hospitals weren't very good at getting their act together and seeing these patients quickly. So I would hope that one of the things we would start to see is that baseline vision improves, and that we get more eyes that start off with a good level of vision at the start of treatment rather than later. So, and I think that's hopefully going to be a COVID effect. Whether we see that or not, I'm not sure.
That it's quite clear now, isn't it, from both the audit reports that you've produced, Martin, that the better the vision when treatment starts, the better the vision will be down the line. It's really crystal clear, this, isn't it? And the delays are therefore really critically important.
Yes. So if you said to me a different question, what are the key things? I'd say it's get treatment started quickly, get that monthly treatment done on time, and also try to make sure that you have the right amount of injections. And essentially the way to get that is to avoid any delays. So at the moment, we can't quite capture delays that have happened. And even when we can, we won't know, was it because somebody was away on holiday or they had a wedding to go to or something like that? Or was it because the hospital didn't get its act together or kept cancelling the appointments? But at least we'll have a measure of how often appointments were cancelled. And that would be a useful thing to be able to do. And inevitably, if your appointment gets cancelled and your treatment gets delayed, then you don't get as much as you might need. And that's likely to lead to a poor outcome.
What you've got roughly 80 centres. Do you know what proportion that is of the total? Is that most or nearly all or about half, or do we know?
I don't know actually, Kathy. You might have a better handle on that. I think it's probably more than half, but it might be 70%, but I think it's not that many. One problem we have is that NHS trusts keep amalgamating. So just when you think you've got the name of one and it changes its name and it moves in with somebody else, so it's quite difficult to contact the right person. And then also the independent sector is, I've got to watch what I say here. Anyway, is interested in injection treatment because I think that's a profitable opportunity for them. So there are more and more independent sector centres setting up, and it's very difficult to keep track of them. So we're probably capturing about 70% of organisations. It's probably that sort of number, but we'd like it to be much more. I think in Scotland and Wales and Northern Ireland, they're rolling out electronic records, which they either don't have or don't universally have. So I think when the rollout of electronic records in the Wales, Scotland, Northern Ireland is completed, we'll certainly have more centres, and we'll definitely have better coverage of the nations outside of England.
It is surprising, isn't it, how there are still so many centres without electronic patient records in 2024. It is surprising, I have to say. But so actually, patients really can make a big difference in this by asking the question: have you submitted data to the National Ophthalmology Database, AMD Audit? And if not, why not? Because patients and the NHS need to know this information, don't they? They need to know it.
Yes, I think patients can do quite a lot. Quite often, as a doctor in an eye clinic, you might be a big fish. Sorry, you're a big fish. Sorry, you're a big fish, but in a small pond. By which I mean it's in a small part of the hospital. So the hospital doesn't really have any performance indicators that it needs to monitor for eye clinics. It does for casualty. There's the 4-hour wait, there's the discharge from hospital, there are all those things. But actually, ophthalmology is a small thing. So I think the patients can make quite a lot of noise to try to persuade organisations that where the clinicians would like to take part, but for whatever reason, it's not happening. I think just to remind them that the audit does exist, and taking part is important. And I think it provides reassurance to patients and to staff that they're providing a good quality service, particularly when the cost of AMD treatment in England alone is meant to be £500 million. So it's important to make sure that that money is used efficiently. And I think taking part in the audit is one way of doing that. Kathy, you're still on mute.
Sorry. A question about any data on dry AMD. I know this is very different, and of course there is no no treatment for dry AMD. So presumably there is no data at all on dry AMD.
No, I think there isn't any data here directly on dry macular degeneration. For a lot of the eyes that do have a big deterioration in vision, my experience is that that's often not so much because the treatment's not working, but because the vision is lost either due to scarring or due to the development of dry macular degeneration or atrophy, as its other name. So there isn't specifically data about that. If there was to be a treatment for dry macular degeneration that was licensed, which means the drug company can market it, and then it was approved by the National Institute for Clinical Excellence, which means the NHS can prescribe it, then this model would lend itself to collecting data about dry macular degeneration just as well. But that may or may not be a priority. I suspect NICE might insist that the company collects some data about how well it works, not in a clinical trial whereby patients have to attend every single month and they get their vision checked every single visit by an optician, but how well does it work in the real world? And as I said before, patients treated in the real world often don't do quite as well as patients treated in clinical trials, and there are various reasons for that.
Well, you can imagine the real world gets in the way, doesn't it? Clinical trials are very strictly, there's strict protocols and so on, and of course are not applied when you get into the real world. Here's a question that somebody would like included perhaps in the audit is, does this centre have an ECLO? ECLOs are quite important characters, aren't they, in clinic scenarios in terms of that sort of wider care of a patient. Does a clinic have an ECLO? That's quite...
So that's an interesting thing, actually. I'll have to remember that. So we don't capture that data in the as part of the audit. So in the electronic record that we use in Leeds for the eye clinic, we can record as free text that we've referred somebody onto the ECLO, but it's not, it's not a box that's ticked, so it wouldn't come out in the audit. But that would definitely be something that we could collect it as an experience measure, because I know that patients rate contact with an eye clinic liaison officer and access to the low vision clinic. They're both important. So those are things we could collect as part of the experience of your overall, how your care was provided, if we got that up and running.
Yes, and I think it's Emma actually, our own Emma saying, be interesting to see if clinics with ECLOs have better patient outcomes.
Mm. Yeah, yeah.
Maybe,
I would imagine they might have better patient satisfaction.
yeah,
Whether they would get better outcomes, I'm not sure.
maybe people, because it's slightly worrying, this 20% of people who fall out of treatment after a year. Was that your figure, 20%?
Yes, so I think the last time I presented, I might have said lost to follow-up, but I think that's not strictly true. So these are just patients who didn't have a visit recorded at 1 year and 2 years after their treatment. And it wasn't on the exact day, it was plus or minus 2 months roughly. So we thought we would have picked up most patients who were still having ongoing treatment. But exactly what happened to them, I don't know. Most of them were not, most of them appeared to be alive. So I think some of them might have been away or might have moved to another unit, but I suspect quite a lot of them are actually people who've started having treatment, and then either because their experience of treatment or the outcomes or their other health problems has meant that they are not able to continue with treatment quite as often as is necessary.
Yeah, and I think that latter point, that other health conditions take over very often, and people just find it all too much to get to the clinic. But by and large, we know that patients are very resilient and very determined to have injections. And actually, there are other types of patients with diabetes, for example, we know are much less. They disappear much more, don't they? They're not as regular as attending as the AMD patients. Is that your experience, would you say?
Yes, yeah. No, I think that's definitely the case.
So somebody's just asked here, they missed the start of it, but does the audit, and you haven't mentioned it, so I'm guessing not, differentiate between the types of drug that are given?
It doesn't, and no, it doesn't. You might be able to infer that. So if you knew that a particular drug had come out at a certain point, you might be able to look and see if outcomes after that date were better than others. I've never really thought that it's the role of the audit to state what treatment patients should be given. You know, we don't have that data. And even if I knew that the outcomes were better this year than last year, there could be a whole range of factors behind that. As we talked about before, it might be down to the COVID and whether patients were able to come to get started treatment quickly. So I don't think it's my job to tell my clinical colleagues what drug they should be using, but that's a decision to be made locally. I think it's up to units to try to work out if there are therapies that might be longer acting, then probably it's to their advantage or to the patient's advantage to have therapies which are longer acting, so they have less burden of treatment, less number of visits, and that just makes the men's more capacity for everybody else. So that's mainly down to each individual unit, and it could be they don't have a choice. It may be that the Integrated Care Board has stated that this is the treatment that must be used because they think that that's the most cost-effective option.
Yeah, so something that's troubled us a little bit at the Macular Society is there are now some of the licensed drugs, the newer licensed drugs, which are quite long lasting, aren't they? 4 to 6 months between injections, and some of the newer biosimilars are biosimilars of the earlier drugs that needed to be given more regularly. And you could see how the choice of drug could impact if there's a capacity problem in the clinic, for example, and that means patients are delayed on having their 4 weekly or 6 weekly injections, you could see how that could have an impact on outcomes.
Yeah, no, I'm sure you're right. My only slight caveat is that often the way the clinical trials were done is that you could argue they're designed in a way that's going to make these so-called longer-acting therapies look good. So whether that's borne out in real-world practice, I'm not sure. So the audit might give us some data, for example, next year to say that actually outcomes have suddenly got a lot better. We did try to capture what was the average interval between treatments at a year. So we're patients who are still in a year where they're having 6 weekly treatment or 8 weekly or 10 or 12 or 14 weekly treatment. And if there's a sudden big game step change in 2 years, you might infer that actually that can only be because these longer acting therapies are around. So we're not directly collecting data, but you might be able to infer from it that there is some data to support these of so-called longer acting therapies. Yeah.
Good. Okay. All right. That's fine. Thank you. So there was some information about missed appointments. You're hoping to gather that. So I think we've probably covered most of the particularly relevant questions, but I'm awfully sorry we run out of time. Again, it's gone so fast. Martin, thank you very, very much indeed for a great talk and beautiful slides, really beautiful slides. So interesting. And we really want you to come back and do the third audit report, please, and tell us what has changed again. But in the meantime, thank you so much, everybody who's joined us this evening. I'm sorry if we didn't get to your question. If you've got a specific question about macular disease and you want an answer, do use our advice line, our helpline, 9 to 5, Monday to Friday. The number is on our website, but it is in the chat, 0300 30 30 111, 0300 30 30 111. Very knowledgeable team on the advice line, on the helpline, and they'll be able to give you lots of answers. This has been recorded and it will be on our website in a day or two. So if you want to see it again, or you know somebody who might benefit from seeing it, do please tell them about it and encourage them to have a look at the link on our website. Martin, thank you again very much indeed. We shall be back next month, which will actually be my final webinar, as I am retiring from the Macular Society in July. So I will be joined by my dear friend Peter White from the In Touch programme for a final My Macular and Me webinar, and I hope you'll be able to join us then. We'll be joined by very eminent Director of the Institute of Ophthalmology, Professor Andrew Dick from University College London, also to discuss the past and what lies in the future for macular research. So I hope you can join us then next month at the same time. Martin, once again, thank you very much indeed. Have a lovely evening, everybody, and I hope you'll join us next month. Thank you so much. Good night.